Hello dear friends, how are you doing today? I hope you are doing well. Welcome to another question of dermatology. You review a 24-year-old man who has recently presented with large psoriatic plaques on his elbows and knees. He has no history of skin problems. Although his mother has psoriasis, you recommend that he use an emollient to help control the scaling. What is the most appropriate further prescription to use as a first-line treatment for his plaques? Okay, this question is asking about the first-line treatment for their psoriasis. Okay, A. Topical steroid. B. Topical steroid plus topical calcipotriol. C. Topical coal tar. D. Topical calcipotriol. E. Topical dithranol. Okay. The best choice for the treatment of psoriasis is topical steroid plus a topical calcipotriol. And the answer is topical steroid plus a topical accompanied by a topical calcipotriol. Explanation. Okay, psoriasis. Psoriasis is a chronic immune-mediated skin disorder characterized by well-demarcated erythematous plaques with silvery scales, most commonly affecting the scalp, elbows, knees, and lower back. It results from an accelerated skin cell turnover due to immune system dysfunction. Okay, the mechanism is accelerated skin cell turnover due to immune system dysfunction or any problem in the immune system. Psoriasis can range from mild to severe and may also involve joint, which we call it psoriatic arthritis. As we can see here, demarcated erythematous plaques with silver scales. These are their features and specifications of their psoriatic plaques. Demarcated erythematous plaques with silvery scales. Okay, management of psoriasis. NICE or International Institute for Health and Care Excellence recommends a potent corticosteroid applied once daily plus a vitamin D analog applied once daily and applied separately, one in the morning and the other in the evening, for up to 4 weeks as initial treatment. The patient is using a potent topical steroid plus a calcium analog, a vitamin D analog, then one must be applied in the morning. For example, corticosteroid applied in the morning, and the vitamin D analog must be applied in the evening. They must be separate, and 4 weeks as initial treatment. The duration of the treatment must be 4 weeks. Management of chronic plaque psoriasis. Regular emollients may help to reduce scale loss and reduce pruritus. In first-line treatment of psoriasis, NICE recommends a potent corticosteroid applied once daily plus a vitamin D analog applied once daily, and as we said, applied separately, one in the morning and the other in the evening, up for 4 weeks as initial treatment. And second line treatment. If no improvement after 8 weeks, then we can offer a vitamin D analog twice daily. If the patient is using a vitamin D analog once daily and there is no improvement after 8 weeks of receiving treatment, then for second line we must say the patient to use vitamin D analog twice daily, once daily potent corticosteroid and twice daily vitamin D analog. And third line treatment. If no improvement after 8 to 12 weeks, then offer either a potent corticosteroid applied twice daily up to 4 weeks, or a coal tar preparation applied once or twice daily. Okay, the sideline. If there is no any improvement after 8 to 12 weeks, then we must offer a potent corticosteroid applied twice daily up to 4 weeks, or a coal tar preparation applied once daily. And short-acting dithranol can also be used. Psoriasis have different types, and as we can see here, guttate psoriasis. We can see here psoriatic erythroderma. We can see here pustular psoriasis and vulgar psoriasis, which are different types of psoriasis. Okay, here we can see also the involvement of the scalp with psoriasis. Okay, this one can be vulgar psoriasis or psoriatic erythroderma. Okay, using topical steroids in psoriasis. As we know, topical corticosteroid therapy may lead to skin atrophy, styria, and rebound symptoms. And while prescribing topical corticosteroids, we must consider this point. Systemic side effects may be seen when potent corticosteroids are used on large areas, example, more than 10% of the body surface area. Okay, if we are using potent corticosteroids for more than 10% of the body surface area, then systemic side effects can show themselves. Okay, NICE recommends that we aim for a 4 weeks break before starting another course of topical corticosteroids. Okay. They also recommend using potent corticosteroids for no longer than 8 weeks at a time, and very potent corticosteroids for no longer than 4 weeks at a time. Okay, this one is also important. Vitamin D analogues. Example of vitamin D analogues include calcipotriol or with a commercial name of Donox, calcitriol, and tacalcitol. Vitamin D analogues work by reducing cell division and differentiation. The adverse effect with vitamin D analogues treatment is uncommon. Unlike corticosteroids, vitamin D analogues may be used long term, and unlike Coltor and dithronol, vitamin D analogues do not smell or stain. They need to reduce the scale and thickness of, they tend to reduce the scale and thickness of plaques, but not the erythema. While treating with vitamin D analogues, we can see the reduction in the scale and thickness of plaques, but the erythema will not be improved and the erythema remain. A very important point, vitamin D analogues should be avoided in pregnancy. Unless adverse effects are common, they must be avoided in pregnancy. The maximum weekly amount for adults is 100 gram. Okay, the maximum weekly amount of using vitamin D analogues for adult people is 100 gram. As we can see here, psoriasis in a baby before and after treatment. This is in the Botox involvement, and here we can see the improvement of receiving 6 weeks of calcipotriol. The scale is improved, but the erythema is remain, as we can see it. Steroid in psoriasis. Topical steroids are commonly used in flexural psoriasis, and there is also a role for mild steroids in facial psoriasis. If steroids are ineffective for these conditions, and vitamin D analogues or tacrolimus ointment should be used second line. Patients should have 4 weeks breaks between courses of topical steroids, and very potent steroids should not be used for longer than 4 weeks at a time. Potent steroids can be used for up to 8 weeks at a time. The scalp, face, and flexures are particularly prone to steroid atrophy, so topical steroids should not be used for more than 1 to 2 weeks per month. As we said, the scalp, face, and flexures are particularly prone to steroid atrophy, so topical steroids should not be used for more than 1 to 2 weeks per month. Okay. Scalp psoriasis. NICE recommends the use of potent topical corticosteroids once daily for 4 weeks. If no improvement after 4 weeks, then either use a different formulation of the potent corticosteroid, for example, a shampoo, or mousse, and or a topical agent to remove adherent scale. For example, agents containing salicylic acid, emollients, and oils before application of the potent corticosteroid. Face, follicular, and genital psoriasis. In face, follicular, and genital psoriasis, NICE recommends offering a mild or moderate potency corticosteroid applied once or twice daily for a maximum of 2 weeks, and a secondary care management. Phototherapy. Narrowband ultraviolet B light is now the treatment of choice. If possible, this should be given 3 times a week. And photochemotherapy is also used, like Soralan plus ultraviolet A light or PUVA. Adverse effects of phototherapy including skin aging and squamous cell cancer. And systemic therapy, like with oral methotrexate, is used as first line. It's particularly useful if there is associated joint disease or psoriatic arthritis, as we said. Cyclosporine, systemic retinoids, biological agents like infliximab, etanercept, and adalimumab can be used in treatment for psoriasis. Ustekinumab, which is an interleukin 12 and interleukin 23 blocker, is showing promise in early trials. Mechanism of action of commonly used drugs. Coulter probably inhibits DNA synthesis. Calcipotriol, which is a vitamin D analog that reduces epidermal proliferation and restores a normal horny layer. And dethronol, which inhibits DNA synthesis, wash off after 30 minutes is important. It must be washed off after 30 minutes. Side effects, it has some side effects like burning and staining. We explain about steroid is different types of steroid according to the potency: mild, moderate, and severe, and very severe or very potent corticosteroids in our YouTube videos. For more information, you can watch them. Okay, here was a short explanation about psoriasis, its presentation and management. Thank you for your attention.